Good morning, everyone. Good morning, and welcome back to day 2. It's great to see everybody joining in. We have another packed agenda for everyone today, and so we are going to get started here. So, welcome back. Again, my name is Maura Little. I am the Executive Director of Cambia Grove, a healthcare innovation hub focused on advancing impactful innovation to support a more person-focused and economically sustainable healthcare system. Today, we are looking at the future of incentives. What are the possibilities? What's the future hold? Let's look into the crystal ball and hopefully make some things happen, make some partnerships happen. As I go over a couple of housekeeping items for day 2, I would like to welcome attendees to share takeaways from day 1. If you can share your takeaways from day 1 in the chat function, I will take a look at those and start reading them off to ground us in what was discussed on day 1. So if you can go ahead and start sharing those in the chat function, that would be amazing. Couple of housekeeping items before I welcome our first 2 speakers to the virtual stage. This is going to be in a section where we have our graphic recording artist joining us again. Sarah Goon, who is the graphic recording artist from Ink Factory, will be sharing her screen during this segment of our program. So feel free to adjust your screen as you might have done before to either watch or minimize the screen from Sarah's incredible artwork. So when Sarah's screen will be shared, of course, you can minimize or increase or decrease. All right, I'm gonna go ahead and look at some of the chat. If you have a good takeaway or a key takeaway from from yesterday, please do include it in the chat. A couple of things that I heard were around the importance of price transparency. I heard that we had that incredible patient panelist, Mike, joining us with the background in cybersecurity and how important cybersecurity is as we advance some of these solutions. I heard of the role of the employer and how the employers really set the stage back in the Kaiser shipbuilding days, and how employers can potentially help shape the future of where we go. I know we're all getting our coffee and getting settled in. Any other takeaways, feel free to add them into the chat. Okay, well, I'm watching the clock and I do know that we have a packed agenda. And so what we are going to get into in the next segment of our program is a fireside chat on the path forward. We have 2 incredible people joining us to talk about the pathway forward and where do we go from here. Dr. Marion Couch is the Senior Vice President of Healthcare Services at Cambia Health Solutions, and Dr. Farzad Mostashari is the founder and CEO of Alidate. I have been super excited about this portion of our event, and I've had the opportunity to get to know Marion and Farzad on some of our prep calls, and I know that we are all in for a treat. All right, with that, it is now my pleasure to welcome Marion and Farzad to the stage. Take it away.
Hello.
Hey, Farzad, how are you?
Doing great. Nice to see you.
Thank you. I remember during my time at CMS, I went to a conference on value-based care and team members from Alidate were there. And I was so impressed by not only their expertise, but their passion. It seems like you've created a company that has a great value proposition. And so I wondered if you could share with the audience a little bit about your background, because I'm going to ask you how that formed, how you started your company.
Yeah. Let me take a couple minutes because there's
okay.
there's an arc there. Yeah. So I'm a internal medicine doc, but I went right into public health. I spent 10 years at the New York City Health Department, and healthcare never really made sense to me. And when I was in training, patients would say to me, "Oh, how much is that going to cost?" And I didn't want to think about money. And I'd be like, I was proud, Marion. I was proud that I didn't know how much that thing was going to cost, because I was going to deal with the science and the technology and the evidence-based medicine.
Right.
And that was wrong. Like, because like it matters if patients can afford the scan or the medicine or whatever I offer them. And then I went into public health, and I was like, why is it that we're not focused in healthcare on saving lives? Why is it that we spend so much money on strokes after they happen, but we're not spending 5% of that on preventing strokes? And I was wrong not to think about the financial incentives. That the fact of the matter is, we have created the system where it's really, really profitable to treat strokes. And it is even for nonprofits.
Yeah.
And nobody makes a lot of money preventing strokes. So I spent 10 years thinking the problem was a technology problem. The problem is an information problem. The reason why we don't control blood pressure to prevent strokes is because we can't measure blood pressure, and we need to roll out electronic health records to the whole country, right? And then we did that, right? I went into the federal government and spent 5 years during that real steep upward curve, when we went from 9% of hospitals to 90% of hospitals having electronic health records. I was in charge of that rollout at the Office of National Coordinator for Health IT as the US National Coordinator, and blood pressure control didn't budge.
Yeah.
And then I was like, okay, after 20 years of trying to do public health from a policy perspective, from a technology perspective, I was like, okay, I give up. Like, guess what? Money matters. The financial incentives in the system matter. Let me find some window in American healthcare where preventing the stroke is actually more profitable than treating a stroke. And there was this thing called accountable care organizations that was being rolled out in 2012, 2013. And it never totally made sense to me that you would make hospitals the center of that whole thing.
Right.
Because I was like, well, hospitals, they're dependent on hospitalizations. It's just hard for a hospital to focus on preventing a hospitalization. But if you go to independent primary care docs, and if you tell them, if you can do better prevention and prevent a hospitalization, you get to keep some of it. Why, that's a long Archimedes lever. So, and yes, of course, technology is and practice workflow change and coaching is at the heart of it. But started the company 7 years ago, and the express purpose is to help primary care prevent hospitalizations, and contract with payers like Campia to say, let's share together in the value that we create together. So that was 7 years ago, and now we're in 35 states. We have about $12.5 billion a year under management of what we're accountable for on global risk contracts through primary care. About 8,000 clinicians, 800 practices across the country.
Before I go on to talk about alignment, Farzad, how important was it to have those experiences in the federal government and in New York City, and the other experiences you had in sort of the policymaking and regulatory arenas? How did that shape how you approached your startup?
I think it was pretty important. I mean, Medicare has led the country on so much in terms of payment reform and delivery transformation, but there are a lot, speaking to the innovators out there, there's a lot of people who are afraid of regulatory risk, like people who are not afraid of technical risk or execution risk, right? Who take risks, like risk is the business of an entrepreneur, right? Of an innovator, but they're terrified of like, oh, I don't want to go into this thing because someone could wake up tomorrow. I've literally heard people say this, Marion, right? Someone could wake up tomorrow and change the rules. And like, I knew that's not how it works.
Yeah,
Like I was one of those people who made those rules.
it's hard.
And right. But it's also, this is the one big secret I'll let everyone in on. The big secret is pretend that the regulator is actually a smart human being who wants the best for their country. And then think to yourself, well, what are they likely to do? Right? And if they're likely, if the right thing, if you are a really smart person who understands policy and evidence and wants to do the right thing for the country, and if that person does something that is going to hurt your business, then you should think twice about your business model, right? If you're like, well, we're living off of, take one example, risk adjustment in MA. And if the federal regulator tomorrow whacks the risk adjustment factor, then our whole business would go under. Then I would say, maybe you should worry about that. Maybe you should think about what business you should do, such that if the regulator did their job, it would be better for you because your fundamental business is aligned with what the policymaker wants. And that's, if you do that, then regulatory risk becomes regulatory opportunity. When we started this company, everyone said, those ACO things, that's never gonna work because the rules are terrible. And they were. And I had confidence that I could start the business and that the rules were gonna get better. And they have now through cycle after cycle of regulatory rulemaking, they've gotten much, much better. And now there's a sustainable business with the rules, and they're going to continue to improve. So I think that is the perspective, I think, of having been a regulator, a policymaker. It's helpful.
Farzad, I so appreciate you saying that. I wasn't in federal government as long as you. I was there for about a year and a half. But that was my experience as well, is that there were very well-intentioned people who were there for 20, 30 years, some of them. I mean, they really are, in my mind, true public heroes. You know, they go to work to do the right thing, and they do iterate, and they're very thoughtful, they're very careful. So I appreciate your saying that, because I do feel that those that view policymaking as, you know, whiplashing back and forth, I don't think that's right. I think it's hard to move that. And I think there's a path forward that they're iterating on. And I agree with you. I see it getting better. You chose to form Alidate around alignment in terms of alignment of sort of payers and providers. And for some people, for instance, when I speak to financial people, that's kind of a squishy term. And yet for a provider, it makes all the sense in the world. Tell me how you came to focus on that as a concept that you have built Alidate around in a way, in that you're helping the payer and the providers see how to work together in a partnership going forward.
You know, there have been so many efforts at health reform. And oftentimes it pitted one or two, was like good for one or two of the three key entities in the system. And I know Cambia Grove talks about the 5 Ps, but in this triangle that I'm talking about, there's really the 3 Ps that I'm talking about, right? The providers, the docs, what's good for the doc, the person delivering the care, what's good for them. The second is the policymaker, right? The public, what's good for the public, what's good for society, what's good for the payer, right? The purchaser of care, fundamentally, like, where does the money come from, right? And then the third and most important is the patient. And there have been things that are, you know, good for provider and patient, but bad for purchasers or payers, bad for society, right? Those things don't last because we can't afford it. There have been other things where you have alignment between the docs and the payer, but it's not good for the patient, or at least the perception is, right, as the way managed care was, that people felt like, oh, they're being stinted on. And so then that can't get sustained because it's not the right thing to do. And I felt like if we're going to create a sustainable business for the next 20 years, we have to hit the bullseye, and it's got to be, and it's literally our credo at Aledade, is good for patients, good for doctors, good for society. And if you can get that alignment, if you can get people on the same side of the table, then you don't worry so much about all the fine-tuned, like how do we lay all of this down and make sure that contracts that we enter into have every possible thing imagined, because the principle is we're on the same side. And you move from a zero sum, I win, you lose negotiation type of thing, particularly with the payers, to where we can together, like I can literally go to you and say, listen, like we both, like we're trying to grow this thing, right?
Yeah.
And you're like, yeah, because it's good for me if you grow, right, your business. And I say, okay, well, the docs aren't going to sign this contract because this isn't going to be sustainable in year 5. And you're like, oh, right. Our goal, right? We're on the same side of the table, as opposed to we're constantly battling over pay me more now, right?
Yeah.
And that's the difference between fee for service, where it's all been about payers and providers, fiercely like fighting over a dollar, more pay, less pay, right? And it's always zero sum, and it ends up being a game of who's got more leverage. And
Right.
that creates consolidation, that creates lack
Right.
of competition, lack of choice, and like good things have not happened with that. We've had higher prices, less choice, lower quality with the consolidation. So we're providing an alternative where we and the docs, for the first time, the docs are feeling like they're on the same side as the payer.
I think that that's a huge new normal. I saw that happening from my perspective in health systems for 30 years in leadership roles. That was starting to happen. And you said something earlier, we weren't approaching healthcare right. We were failing. It didn't make sense. It didn't. And it didn't, I think a lot of physician burnout is that it doesn't make sense to physicians. We go in it for one group, one reason. We're trained, by the way, not to worry about cost, just to come back to that. We are literally trained not to. It's almost like unethical. And that was wrong. So our new normal was starting to happen. And I feel that pandemic probably pushed that transformation or accelerated it. And so you're in the space that you're working on alignment. And I really salute you for that. The other thing you focus on are outcomes.
Yeah.
And I think that that's something we're also, agreed upon outcomes in a partnership is something I'm really interested in. Can you tell me a little bit more about what the outcomes are you're going after with Aledade? And then maybe as a follow-up question, what's sort of the timeline? And the reason I ask is sometimes I worry when you think about value-based care that large employer groups want results this year. And I wonder if that we need to set expectations a little bit differently in terms of, ACOs came out 10, 12 years ago. The Innovation Center at CMS has been for 10, going on 11 years. And we're learning all the time. But I wonder if you could comment on what outcomes you're looking at and help us understand when we might see the results of those outcomes.
Yeah, no, great, important framing question. Look, I've gotten a lot of pitches from startups, and it's oftentimes some version of, yeah, and we'll be paid for this today, and then I promise, pinky swear, it's gonna reduce your costs. But pay me now, right? Because like that's my model. And you're like, well, are you sure it's gonna reduce? Oh no, yeah, trust me, it totally reduces costs, right? And we're like, oh, okay, then how about you go at risk? Then how about you only get paid if it reduces cost? And then those entrepreneurs are like, oh, what? No, I can't take that risk. I don't control costs. Like, well, okay then, right? So that is the hardest step to take, is when you're starting business, to say, do I feel so confident? Am I willing to take that risk on that if I don't produce the hard outcome that my partner is looking for, I'm not going to get paid a dime. Now, here's the thing. Many people say, oh, I'll start the business this way, and then we'll pivot to value-based contracts. Never going to happen. It's never going to happen. Unless you start that way, you're never going to be able to take the hit to like
Farzad,
it's
I so appreciate your saying that. I hear that all the time as well. Great point.
right. So we started the business and it was so hard to start off and say, like, we're going to have zero revenue this year. We're going to spend a bunch of money. We raised $300 million. It now seems modest. We're going to spend the money this year. We're going to build the technology. We're going to hook up the practices. We're going to hire the staff. We're going to do the coaching. We're going to, right. And then in our first year, Marion, 2015, we reduced hospitalizations by 7%. And we were like, this thing's working, right? And then all the claims came in. And then 2 years after we'd started the company, we were expecting our first checks for having created savings based on that 7% reduction. And guess what? We didn't get paid anything because the hospitals adjusted their clinical documentation intensity, whatever, CDI program, and they coded a bunch more sepsis, and the cost of each one of those remaining hospitalizations was adjusted upwards so that they maintained their revenue. And we're like, okay, got to do it again. And so when to your question of how long does it take, some things can happen quickly, right? We increase primary care pretty quickly. We decrease ER visits, we decrease hospitalizations. But total cost of care is hard to move, and it takes a couple of years. I used to say 3 years. I used to say it takes 3 years. Now I say 2 years. After 2 years, pretty sure that we're gonna be able to have the initial like cost savings, and then it keeps growing, right? So we're now up to 15% reduction in all cause hospitalizations, 13% reduction in all total cost of care compared to the region. And that's real money, right? 13%, if you can get 13% reduction in total cost of care using primary care, which is 5 to 8% of cost of care, then you've created a lot of value to go around.
I think that's really important. Do you see?
Actually, Marion, can I ask you from Cambia's from Cambia's point of view, what are the outcomes you're looking for?
You know, really an evolving answer to your question. And we're a payer, of course. So we're looking at a return on investment, but that can take many forms. And I actually think, I gratefully asked me because I've been part of groups that have devised great innovations, but if you can't demonstrate a return on it, I can't use it. And that the CMS can't use it. And a lot of people can't help you with it. So it's just a really important concept. For me, return on investment is related to reduced utilization, or again, the easy ones to think about, reduce hospital admissions and readmissions and ER visits. Those are straightforward, and they're important, by the way. I think that if we kept focused on those, that would really drive a lot, and those are important. But we also, and sometimes I think this is the value of spending time in the regulatory government space. We also really look at how it relates to our quality improvement. We get paid for star ratings, and we really want to have a great reputation. So if you help us with star ratings, which is quality, you understand the quality space, that gets our attention. That's really important. We compete ferociously for consumers, members. And so if you help us with retention or satisfaction, that's huge. But I'll tell you, there's one thing that we're struggling with, and I'll just share it because if there's innovators out there, it's probably a great conversation for them. We started thinking about an outcome being patient engagement, and we thought that was really important. But unless we can then quickly take that patient engagement set of metrics and link them to cost or quality, we can't stay there very long. So it's hard, right? So, and I would say to you, your comment about it takes 2 to 3 years is true. And we see that at our end as well. But we are very interested in access, total cost of care, quality, member retention, engagement, satisfaction. And so those are different things that we always look at. But I will tell you, there's going to be more and more pressure. This is Marion speaking, not Canby, our regents. More and more pressure for us to show reduction in total cost of care. And I'm always fond of saying, and I know your company does this in spades, let's talk about increased value, which is total cost of care reduction and increased quality, and really have to match the two. That's one thing I really bring back to my company, Farzad, is we can't talk about reduction in total cost of care unless we're talking about the quality component there. The two have to be linked. And that will protect the member. That's the value path forward. And so for us, that's really important. But I guess the best way to answer it is we're evolving too in terms of how we look at it. And you just have to be able to show us something beyond patient engagement, for instance, and access. We're rapidly evolving into a harder set of, a more rigid set of criteria for return.
Yeah. A great point about the quality. We one of the things when we started working in North Carolina, we went from standing start to we now have about 377,000 lives that we're accountable for in North Carolina, 230 practices growing every day in a real tight partnership with the Blue. And I went to their board meeting where they introduced the partnership before we started. And I said, well, what really matters to you this year? We're not going to, it's going to take us a couple of years to show the cost savings. We actually got 6% cost savings the first year there, but that was not expected. But what matters to you in year one? What can we show? And they said star ratings.
Right.
So when we started with these practices, they had those patients who were cared for in those practices had the clinical quality measures for star ratings was at 2.8, which is not very good.
Yeah.
And within 6 months, we got to a 4.5 star rating, right? Because we were able to provide at scale the kind of tools, data, partnership, workflows, patient outreach that the payer couldn't do at scale with 300 disparate fragmented practices. So we were able to act on their behalf without the payer having to pay anything until they actually got the results on the savings side. But I think that quality point is really important to assure people that this iteration of value-based care is not managed care where people's perception was, this is gatekeeping, this is they're stinting, I'm not getting the thing that I want, right? It's you get more, like we give people 20% more primary care. Their doctor calls them after they go to the emergency. It's more like concierge that happens to save money. It's you getting more, not you getting less. And I think that's really an important part of the story.
And you know, Farzad, that's huge, right? I mean, that's an amazing concept. When you're in a fee-for-service world as a clinician, and it's all about volume, man, you're just churning them out. You're just going from one patient to the next. I happen to be—
How short can that visit get?
Yes, I was just going to go there. I was going to tell you, as a surgical subspecialist, I was down to 10 minutes for return and 15, maybe 20 minutes for a highly complex surgical patient. And that was the game. And now we've turned it around in terms of, all right, we're going to keep you healthy. And we can call you, we can email you, you can come in, you know, we need to be connected to you. It's huge. And as an aside, and this is not something you're measuring, but this is a hypothesis I have, it's going to help with clinician burnout, which is a huge issue in this country. It's helping clinicians and also the members do what that interaction, you're building around that member clinician relationship. And when I look at startups, I want to make sure that they're encouraging that, and that there's care management around that, and that information is properly shared around that interaction and visit. And your company's done that in spades. So it feels good, is my point too. It feels really good as a clinician to practice in that type of, to be rewarded for practice that way.
It does. And we have, you know, our our practice partners, we have a plus 72 net promoter score
Wow.
from
Wow.
with them.
Yeah,
And
great.
among our employees, right? Like it is really much easier to recruit and retain people when they feel like there's this alignment with what's best for the patient is what's good for us. We won, 15 best places to work awards last year. And I don't think it's because I'm such a, great orator. I think it's because we're aligned. And one of the causes of burnout, I think, is moral injury.
Yes, I agree with that.
And it's that moral injury in burnout in physicians and clinicians specifically, it's that moral injury where you feel like the duty you owe your employer is different than the duty you owe the patient.
Right.
That is so toxic.
Yep, it's not what you signed up for. Yeah, I couldn't agree more. I think it's really important to understand that. I think that that's a huge concept. So Farzad, you're working in primary care. What about the pediatric space and the specialty space? Do you have plans to go into those areas?
Yeah, we actually, North Carolina said to us, we love what you're doing, but we got these peds populations too, not just the seniors. And there are some in the value-based space who literally limit themselves to just Medicare Advantage because that's where the money is. And we said, okay, like we understand that there's less money in peds, but we think that the same principles of more availability, more informed, more engaged primary care as the quarterback of care can provide better care in that context as well. So we are doing peds, we are doing Medicaid. We're the largest provider of Medicare single group in Mississippi, Medicaid, with the Federal Qualified Health Centers in Mississippi, and they're doing great things. And in those cases, in that context, it's heartbreaking. But just seeing how many kids just haven't even done their well child visits.
Yes, yes.
I mean, just that, just like helping them reach out and bring patients in to just establish that primary care relationship can be life-changing for folks. So we are doing it, across all payers, all population segments. I think that's what makes us a little bit different than others, and we're getting good results across all. And that's when you have a practice-centric versus a payer-centric or, business line-centric point of view, because our practices want to be able to do have this information and do this across all of their lines. It is maybe not shocking to you, but I think for people outside of healthcare, it'd be shocking how many different rules and quality measures and for the practice dealing with 18 different payers, how hard it is to get alignment between those payers. I'm like, just tell me what you want me to do, right? Right. But I think we are able to be the clutch or the transmission between all of these different payers and the practice, and we're able to take the practice's EHR data, combine it with other claims data, and feed it back to the payers in a way that minimizes the burden on the practice, and then vice versa, have some more simple playbook that says, okay, here's the playbook for transitions of care. You don't have to try to coordinate with 18 different payers.
I think that's huge. As a payer, our network of providers is so important. It's huge. It's our engine, and making sure that we then have relationships and payment models with them that they are eager to partner with us because they have choices. And then that helps us grow members because we have this great network of clinicians. So if you're an innovator, any other advice for folks that have seen what you've done and are interested? Any other advice on how you'd gain the knowledge or how you think about what could come as sort of next. I'm not trying to set you up for competitors, Farzad, but if you're trying to learn to be an innovator in this space, any advice? Because I think we've got some, I believe we're going to innovate our way out of these problems. I really do. And I'm excited about that. But if you're an innovator and you look at Alidate and you look at Farzad and you're amazed, what advice would you have for somebody kind of thinking about entering this space?
Yeah, I think there's so much opportunity, right? Like, I think the world isn't, I'm not worried about the fellow travelers, I call them, because like the competition is stasis and status quo and fee for service.
I
That's the
agree.
competition.
I agree
right?
with you. Yep.
So I think we're going to need the world. I think this is going to be a hospital referral region by 308 HRRs across the country, and every one there's going to be a battle. And the battle is, do we move in the direction of monopoly and just raw market power, right? And I'm going to try to get big enough to tell the payers they have to pay me more, right? That's path A. Or like, all right, I guess I'll find the biggest monopolist in the region and the biggest, health system, and I'll go, shelter under their fee schedule. That's
Right.
approach A. And approach B is, I'm going to move in the direction of value, affordability, and quality. And I think we're going to need this village to come together. And I think we're going to need it for home health. I think we're going to need it for post-acute care. I think we're going to need it for rehab. I think we're going to need it for dialysis. I think we're going to need a value-based specialist and value-based behavioral health and value-based, like there is so much room here if you're an innovator to say, how can I really help someone create a value-based offering? The one advice I have, if you're coming from outside of healthcare into healthcare, the advice I would have is get out into the field and feel their pain, right? Like,
Thank you.
don't, like, you gotta sit with, like, you want to help home health providers or physical therapists, like, for God's sake, like, go live their life, like, live it with them and see how painful it is, and then say, how can I help them?
Yeah, I think that's great advice. And I think to not understand that almost borders on arrogance to me. It's just a really important concept. If you believe in lean, it's going to the Gemba. You should really go to the Gemba and really understand the pain points and how to make them better. I couldn't agree more. Do you think, Farzad, value-based care is tipping towards acceleration, or are we still have our work cut out ahead of us? It's clear from my comments, I believe in it. But there was a recent article by a recent director of the Innovation Center at CMS, which creates payment models, not to be mysterious, talking about, work that needs to be done. Where are we as a country? Where are we as a country in terms of this type of work, the value-based care world?
Yeah. I mean, I'll be more specific. I think you're being polite. That article found that of the 50 models they tested, most of them didn't do anything to reduce costs, didn't work according to the actuarial standards. And there were 5 that did, and 5 that cost a lot of money, actually. But I see that as very positive, right? Because we tried a whole bunch of different things, and now we can see what's worked. And the clarity of the evidence is that giving physicians accountability for the total cost of care and then getting out of the way has been by far the model that's proved the most successful. And it's not in the portfolio of the Innovation Center, although elements of it made that migration over. But as part of the permanent program of Medicare, it's the Pathways to Success Medicare Shared Savings Program. And I see I was on a panel with Liz Fowler, who's leading the Innovation Center now at Stat News, and they asked her, well, what's your goal? And she said, I want 100%. It's not just a third, but I want 100. Like, how do we get to 100% of Medicare beneficiaries in an accountable care structure? And I think the way you do it is not by creating 50 new models that you throw spaghetti at the fridge, but you say, oh, here's what works. Let's scale what works. And I think what I'm seeing is much more of the, it is much easier now than it has ever been in the past 8 years I've been involved in this, to go to, for example, a payer and get a value-based contract. It is now more and more, and I think what we need to increase the capacity on the provider side to be able to take those contracts, and in particular, to move to downside risk. It's great to start with one-sided gain share only, where, okay, I'm accountable for the cost I put into it, right? But we need to get to the point where we're truly aligned, which means if costs go up, then I pay you.
Yeah, yeah. Farzad, I thought that, and I spent time at the Innovation Center. I was really excited to be there, and wonderful group of folks. But none of this is easy, and your 7 years is a testament to that. None of this is easy. Yeah. It's all hard, and I think there was a lot we learned in that 10 years of the Innovation Center. I think we learned a lot. And sometimes scale, like thinking about mandatory models, I suspect they're probably going to start doing more mandatory models from the CMS. Yeah. And I think that might sort of help us all understand what direction we're going to go in. But I think there's a lot that we learned. And I just think it completely aligns with this new normal we're seeing in healthcare. And I hope the pandemic makes providers more willing to think about it. My goodness, if you were, again, I think I've told you all I was a surgeon, but I never thought my peers and I would not have work. It just never occurred to me. And during the pandemic, we had no work. We went months and months and months with no patients. That's the fee-for-service world. And there was still plenty of care and things that needed to be done. So those practices, those health systems that had population health or value-based care arrangements had a revenue model that sustained them. Yeah. And they could shift some of their workers to reach out to people via telephone or audio, video, and make sure that they were okay, and close care gaps even when they couldn't see them in person. It allowed them to, I think, survive and even thrive during the pandemic. So I hope that we see new normal, and providers, to your point, who may not have been ready before, having more willingness. We're seeing that, Farzad. When we have conversations, people are bringing that up all the time, 100% of the time. And so one of the things we're going to have to do is make sure we offer them a spectrum of payment models that allow them to go on that journey to value-based care, much like you're doing with your primary care practices. I think. Go ahead.
Oh, sorry. I was going to say, on following up on the COVID point, I do think that it showed the insanity of a payment model system, where at the time when there's a pandemic and people need care, their practices are fee-for-service practices are going out of business, shutting down, laying people off. It just made no sense. Yeah. And I do think that people who are in value-based models like ours weathered it much better, in part because they had a different revenue stream, but also in part because they had us to help them. So we ended up helping them do telehealth. We ended up helping them get masks. We donated a couple $1 million worth of masks and figured out how to import them. We helped them navigate the policy, helped them with loans, right? And I think one of the other things, though, that's come out of the pandemic, I think we can look at the positive, but there's also a risk here that I think we're seeing a lot of practices saying, gosh, being by myself out here is too hard. Right. And I'm going to take the shelter of an Optum, a private equity fund, a health system. And what we're trying to say is you can retain that clinical autonomy, but be part of something bigger and join in with a network of other independents. And I think that's the opportunity for the payer Alidate collaboration, is to bring in all of those disparate practices, keep them independent, but get them integrated.
I think that's a huge point, and thank you for bringing that up. I think that we are still learning about the unintended consequences of consolidation of physician groups. It's a real important concept. I'd like to invite Maura back to see if there's any questions for us.
Oh my goodness, we have so many. That was fantastic. First off, thank you both. I've got pages of notes at the moment. First question, though, is a technical question. Sarah, our graphic recording artist, it looks like we can only see a portion of your beautiful work. If you can zoom out, I've gotten a lot of individuals hoping to see the rest of everything. Okay, thank you for fiddling with that. I'm going to take, excuse me, I'm actually going to ask a question that I've been thinking throughout this. Oh, wow, look at that. I've been thinking throughout this, and it goes back to something you said, Farzad, that the competition is the status quo. And you've been able to work within building Alidade, building your company within the status quo and kind of being water, following. Are there things that need to get adjusted? Or are there things that are current barriers to getting to this future element of health that need to be adjusted? I guess adjusted is the nice word. And then Marion, I want you to answer this question as well.
Yeah. Of course, there's many. Anytime you want to change a complex system, you can't just change one part of it, because the rest of the system reacts to retain continuity. What I found, though, that is the most powerful is the partnership. If we can get the payer provider on the same side in service of the patient, then that's the most powerful combination. And what I will focus in on the major limitation on that is trust. We have spent,
I agree,
decades on opposite sides of the negotiating table. And it's oftentimes like the payers don't really believe it. Like I've literally had conversations where I was like, okay, so we're bringing these practices together, and the payer's like, and then you're gonna come to me and demand higher prices. I'm like, no, actually. And they're like, yes, you are. I'm like, no, we don't. And like, they can't get out of their own way of like actually believing. And this is why we made our business model the way it is, right? So just as this kind of foot in two canoes thing of like, you know, providers, they're in two camps and blah, blah, blah. Payers too have like still like people whose job it is to be like the most hard-nosed contract negotiators, and they bring that same mentality over to where we have aligned incentives, and they're like, we're only going to give you this, and it's like, well, then the docs aren't going to participate in this program. If you win, then you lose.
Mm. Yeah.
Maura, I have so much overlap with Farzad, and I just want to point that out. Alignment is everything. Partnership is everything. Trust is it all. And the one other thing I would say is it's hard to trust and build those partnerships and stay with them for a long period of time. And I'll say something just a little bit tacky, but it just goes to the first point Farzad made about it's a complex system where people's livelihoods are involved. And you just got to understand the power of that. So as a payer, it's really easy for me in my role to just do a lot of prior authorization and utilization management. And I know I'm going to be a hero in my company, and I'm going to, make my whatever you do for, compensation, and it's safe, right? I control that. What's really risky is to give that responsibility over to a group. But if you really want to change the system, that's what I have to do as an example. And that's the work we have to link arms to do together. And that's what makes it hard. And I believe it's also solvable, eminently solvable, but that's the rub, that's the conflict.
All right, so this question might be similar to the question I just asked, but I'm going to ask it anyways because it could take us into a different zone, which is, question is, your stories tend to show that providers have a need for revenue that makes value-based payments harder to implement. How do you overcome the fear in large acute care providers to embrace value-based pay?
I don't know.
Okay.
That's why, like,
yeah,
it's just, yeah.
I'm a surgeon. I'll take a stab at it with acute care. You know, there are examples of it. They're not a lot, but there's great examples of it. And I'll start with the fact that I became a surgeon because I wanted to help somebody, and I don't want to operate on somebody if they don't need it. On the other hand, just to be completely candid, if you don't have a system around you where you can send someone for um, weight loss, smoking cessation, physical therapy, instead of operating on them, if the only thing you have as a carpenter is a hammer to work with, you're going to operate. I mean, I've literally heard surgeons say to me, I'm so tired of operating on patients because they're depressed. You know, this is where we are in the fee-for-service world. So for me, you go upstream and you basically hold providers, the surgeon compensation the same, but you're in partnership. You've got a system where they can send that person for weight loss, smoking cessation, behavioral health, fix their depression, and then your utilization will go down over time. I think that, you know, I'm not naive. The hospitals may not like that because that's some of their revenue too, but it works. You know, you're working to do the best thing for that member. A member not getting an operation or a procedure they don't want is actually a wonderful thing to them. So I think there are ways of going upstream from an episode, a procedure, for instance, for specialists. It's hard though. It's hard. You've got to build those systems in. You've got to understand who you're affecting with that. You have to understand how you might do patient-reported outcome measures so you're not stinting care like we did in the 90s. And, you know, so there are ways, but it's hard. Doable, yes. Where we must go, I feel yes.
I was being a little flippant.
No,
what I mean, yeah, what I mean to say is it's hard. It's much harder, and people aren't going to do it voluntarily if they can preserve the status quo. If you're making good, you know, if you're happy with the current situation, you're not going to go through the really hard work and wrenching work of redefining your business model. So what do we have to do? There has to be choice and competition, right? Competition. Like, what do we need to do to get people to change? Is like they've got to feel like someone else is gonna do a better job, and they're gonna get the volume, and they're gonna get the work, and they're gonna get the rewards. So there has to be, and this is circling back to the consolidation issue. Like, I think that the policy issue that overrides everything is we need to maintain competition if we're going to have a market-based system, or we just go full regulatory and set prices, right? Like, you can do one or the other. You can't you can't do both. You can't do, you know, neither over the long run. But I think if we do create that structure, and then you know, it can be like you're making 5% margin on a hospitalization. Well, what if you got to keep 20% of the, you know, of the cost of not doing it? But you had to do it, and you have a sustainable long-term pathway. And I think that's the key, is creating that sustainable long-term path.
We've talked about upstream for the providers and kind of the system outside of the patients or the consumers. One of the questions is, how can we give? Look at that.
I'm gonna plug this book, actually, which is a great read if people want to go upstream.
Good prop, Farzad. Thank you.
By the way, that was not planned. That FYI. So this question is, how can we give consumers more choice around their preventative medicine, focusing on lifestyle and preventative measures without having to wait for the provider to diagnose an issue?
Well, without waiting for the provider to diagnose an issue. Mm-hmm. So for us, we do like the providers to be involved in that, because it turns out they're good about discovering things that you didn't even know. If you're like me, I probably don't go enough, and I'm probably blissfully ignorant of my health problems, and that's not good, actually. But we also might want to venture, and we are venturing into thinking about health solutions. So you'd have, as part of your point solutions, you'd have the ability for wellness and high performance. In other words, you'd have programs that, as a member of a payer, you know, a health plan, you could sign up for to help maximize your health and help encourage you to figure out how to have good diet, more exercise, smoking cessation, those types of things. So I'll just stop after this more, but I think a lot of health plans, it's not unique to us, are really reinventing ourselves as health solutions and thinking beyond what we needed to do for fee for service and offering our members a portfolio that expands. And we're doing that because the employers want us to. It's a virtuous cycle. Employers want their employees healthy. So we are very interested in wellness and high performance of our members.
I'll just say, I'm a big believer in people having access to their own data, for example. Like we were champions at HHS of the open data movement, and
I agree.
The blue button and the concept of people being able to own their own information and be able to access whatever services they want. I will also say that we've been waiting for a long time for consumerism to show that it will save money. And I'm somewhat skeptical, and I think like Dr. Couch, I think that there's a really, really important role for providers and primary care docs and nurse practitioners, trusted sources, to be involved there in helping guide people's decision making. I don't want to be paternalistic about it, but I think that's just the reality of, putting the burden on consumers to go find out price transparency, where's the cheapest place to get your heart attack treated. That has not worked very well, is one example.
I also think there's a great role for care management, and you don't sort of know when you might need it, but if you have a relationship with a primary care clinician and all of a sudden you need care management for a number of things, it's huge to have that in place. I think the data is really quite striking, and your outcomes are better when you have care coordination.
Mm-hmm.
So you all have provided a great segue to my last audience Q&A, and then I'm going to ask you to any closing thoughts before we go into a ACLC section of our agenda. So this is the last question. We have so many great questions, but as you connect the payers and the providers, how do you handle the issue of data rights and data privacy? And this comes from an entrepreneur who's looking for any strategies about data acquisition and that realm of this work.
Sure. So one of the things that we did at ONC was implement, working with the Office of Civil Rights, the high-tech provisions of the HIPAA changes. And I'll tell you, there are a lot of things that are talked about as barriers to data sharing being HIPAA that have absolutely nothing to do with HIPAA. And if you're doing something for true treatment reason, if you're sharing data for obviously treatment, payment, operations, all of those, you can share data, and there is never a reason why the patient can't get their own information because of HIPAA. It's actually quite the other way around. The patient has a right because of HIPAA to get their own information. But all the time, people think that, HIPAA and the regulations stop information sharing, whereas really what's stopping the information sharing is people want to hold on to their little bit of competitive edge and not share the data. The health systems not sharing with the community docs the discharge information, real-time event notifications with the primary care docs, unless they join their clinically integrated network, right? That we have a term for that now. It's called information blocking. And I think what we need is some enforcement of those provisions on the data sharing side. And I think the other part of it is the trust piece, right? Oftentimes payers have been saying well, we're doing this contract, but we're not going to give you claims data. And thank God we're past that stage now for almost all of our, but it was like a real thing where they would be oh no, I'm not going to give you the claims data because then you could see how much I'm paying someone else for the thing. And we're like, how can I help improve the situation if we're not seeing the same data you're seeing? So I think I would be careful, though. The way that was worded was a little bit tell me how I can acquire data. And it's the point isn't to acquire the data. The point is you got to be helping the patient. And then once you have that straight, then that's the pathway to having appropriate access to the information. And I think too often people come up on the tech world, they have this vision of like, I'm just going to get a whole lot of data and then I'm going to monetize it. Like, that's not how it works in healthcare.
You don't want to follow Farzad on that question. He was like the national expert for years. So, we worked at interoperability when I was at the CMS and with the application program interface so that you can, in a secure, safe way, encourage that flow of information from payer to provider to patient. And I just think we get all sorts of pushback from that. And there will be unintended consequences of, trying to gain competitive edge from posting of prices and price transparency, et cetera. But it's a step in the right direction, and especially done with application program interfaces that I think are going to be a thoughtful way forward. So for us in the payer world, it's going to be work, but we're at least at Regents, we're supporting it quite enthusiastically.
Right. Unfortunately, we are out of time, but I am going to steal last thoughts for this segment. Any closing remarks that you all have? Let's start with Marion as we look at the pathway forward for incentives.
It's going to be innovation. It's going to be supporting innovative companies that build a value case in healthcare. They're not trying to extract money and disrupt. It's innovation that is bringing value. And I'm very optimistic.
Farzad?
It's partnership and trust and relationships. And I'm just want to be very grateful and thankful to Cambia for the partnership.
Fantastic. Thank you both. Thank you for joining us and sharing your expertise. Very much appreciate it. Bye. All right. So everyone, we are going to go ahead and get on with our agenda. Next up, by the way, Sarah, beautiful work, beautiful work. Thank you so much, Sarah, for documenting the conversation. We now have a break. We've got a short break between 10 and 10:15, where at 10:15, we are going to be going into concurrent peer learning sessions, which are hosted by the Accountable Care Learning Collaborative. One note before you all leave for your break, this is the last time that we are convening as a group for this conference. And so I want to just take a moment to say thank you. So thank you for everyone for participating in this 2-day session. This has been incredibly valuable, I know, for me, my team, and a number of you have reached out. And we're going to continue these conversations at the Cambia Grove. Most notably, Cambia Grove is preparing to kick off our annual fellowship in July, which will focus in on that data interoperability piece and component of the incentives question. I also want to make sure to have I also want to make sure to give a huge thank you to our event partners, the Accountable Care Learning Collaborative, America's Health Insurance Plans, Patient Order, and the Pacific Hospital Preservation and Development Authority. It has been incredible to work with these organizations in building this program, this agenda, and we look forward to continuing working with them on all that is ahead. All right, one last thing. We are going to launch one last poll to collect your final feedback for us at Cambia Grove. Of course, these polls help us tremendously in planning out events in the future and how best we can serve you, the innovators in the community. So if you wouldn't mind taking a little time and completing that poll, we would very much appreciate it. All right. With that, we're going to go ahead and close out this segment. Refer to your attendee guidebook and choose to choose one of 2 concurrent sessions. You do have a link in the guidebook. If you have any trouble, reach out to Nick at cambiagrove.com. Otherwise, we will see you back here in about 11 minutes. Thank you all. Hey, Laura, you just went off of mute and we can hear Archer.